Like Dr. Corey said, my name is Jenny Hunt. I'm a VOS Core team member at Johnson City Medical Center, and we'll be expanding into Niswonger this fall. My director, Brent, came and spoke and gave that high-level overview of lean and how we're using it in healthcare, especially at Johnson City Medical Center. And what I was asked to do is come in and kind of give a more in-depth insight focus on a couple different tools that we use at the Med Center right now. So I'm going to focus on A3 thinking and flow cells. So we'll get started. The first thing I wanted to do is kind of outline some objectives so you know what to expect during the presentation. Hope to see that I can meet your objectives. We're going to go over A3 thinking and how it relates to that PDCA model of improvement. We're going to go over the 5 elements of a flow cell and then demonstrate those 5 elements. I'm going to give you some real-world examples from everyday life and then from the healthcare world. So the first thing we're going to talk about is A3 thinking. A3, it doesn't mean anything fancy, it doesn't mean anything special, it's just another word for an 11 by 17 sheet of paper. But the whole concept of A3 thinking and the methodology behind it is something that we use practically every day at the Med Center. It's just a way for us to force teams to be really methodical in how they view problems, how they look at problems, how they get to root causes, come up with solutions, and run experiments with new problems. So the first thing, at the end of every table there should be 2 sheets like this, so if you can take them and just pass them down. The first one, it's not going to be shown up here on the projector, but I'm just going to give you a quick overview of it. This is what the A3 format looks like. It's not on an 11 by 17 sheet of paper. I put it on an 8.5 by 11. But this was actually a real example that was used by a coworker of mine for her interview into the department. Everybody we interviewed, we used to charge them with taking a real world problem, whether that be work or home life, and putting it on an A3 because we wanted to see that they could walk themselves through the methodology. So you can look at this as we're going over the next couple slides. The one I did want to go over that's up on the projector right now is this one, A3 thinking. It gives a really good example of how we tie PDCA to the A3, and we actually give this out during events to bring it more to a clinical level for all of our clinical folks that we have on events. So we have our box 1 through 5. If you kind of blur your eyes a little, they're all the same color, maybe it forms a little P. This is where we focus a lot of our planning. We spend the majority of an event week in doing nothing but planning. We start planning events probably about 3 to 4 months out. We really work a lot on box 1 through 3, really outlining what our reason for action is and then what kind of metrics we're going to look at. Box 4 and 5, that's where the team really comes in. They're getting to the root cause problem there, coming up with solution approaches, so a lot of time in planning. Box 6 and 7 relate to the doing part of the PDCA model. This is where we're running our experiments. We're following up on completion plan items. Box 8 is that check part. We're monitoring the progress from box 2 to 3, kind of watching the metrics. It enables us to do some real-time problem solving if the metrics aren't trending the way we need them to. And then box 9 is that acting part of the PDCA model. What insights can we take to move forward for future events that we have to go through? So if you want to just refer back to those as I go through the next couple slides, we'll go through a little more in-depth description on each box. So box 1, this is really where we outline what our chief complaint is. What are those issues that we've gathered a team together for a whole week to run what we call a rapid improvement event or rapid improvements of continuous improvement. We really outline that problem statement, make it clearly defined so if we were to pull anybody into the event, they know exactly what problems we're there to solve for the week. We also define our scope, so what area in particular are we looking at? That trigger point where we can visually see the process begin, and then the ending point where we can visually see the process has come to completion. So the initial state, this is one that's done in our prep phases. Like I said, we start 3 months out and work all the way up to a week before the event, just continuous prepping for the event. We monitor metrics that are directly going to be impacted by what we've outlined in our reason for action. So what is it we're going to know at the end of 90 days, which is the typical life cycle of an A3, is going to let us know whether the event was successful or not. It's given us a good view of what's happening right now in the current state, so what's going on, and like I said, we use data that can later prove our case for the whole week of running the event. We also outline the attributes here. How we phrase it to the team is if you were to meet somebody and had to describe to them what the current state is, what kind of words would you use? Is it fragmented? Is it broken? Is it inconsistent? Are there silos? Kind of whatever those descriptive words that you would use. So same thing for box 3. We're just transferring the data that we had in box 2, but what we're doing in box 3 is looking to see where we can set those breakthrough targets for improvement. How are we going to get that information? Is it going to be what benchmarks are we going to use? Are we using data from Hospital Compare? Are we getting data from JCO, CMS? Where are we going to get the data to set those breakthrough improvements so we can meet that top quartile? We also outline attributes here, so same thing as in box 2. If we had to describe to somebody what we envision that future state to look like, what are those descriptive words that we would use? So if you're still keeping up, like I said before, when you looked at this example, we're still in the planning phase. This is where we really start our rapid improvement event week. We bring the team in, and what we charge them with doing is mapping out what the current state looks like. All we do is we take a huge sheet of paper, give them a bunch of post-it notes. They go out, they make all kinds of observations of the current state. They map out each process step, and then they also try to identify and capture the waste. Now this is going to help us when we do our box 4, which is our gap analysis. So these are the things that are preventing us and preventing that movement between box 2 to get to box 3. So we're identifying that way, seeing what things stand in our way. This is where we do a lot of cause and effect diagrams, or I know maybe if you're in quality class, we do Ishikawa diagrams. One thing we mainly use is called a 5Y diagram, which is really just an Ishikawa diagram turned kind of upside down or on its side. So we start here with the problem. Then we ask, okay, why does that problem exist? Then we have our first layer of whys. And then we just keep working down to we're about 5 layers deep, which is what we found really helps you identify what that true root cause is. So what we want the teams to do is really get an in-depth 5Y analysis of what that root cause is, because the box 4 can be the pivotal point of an event week, because it helps us set up our box 5, which are our solution approaches, and then into box 6 on those experiments that we're going to run. So we want to make sure that we've done a really good in-depth 5Y and really got to the root of the problem of what we're trying to solve. So box 5, like I said, is our solution approach. These are our if we then we statements. So if you think back to elementary school when we were learning about the scientific method, you can think of these more of our hypothesis statements. So if I do X, then I expect Y to happen. These, like I said, are going to be based on box 4, but we want to make sure these statements are really solid too. Every box, we want to make sure it's solid before we move on to the next box, because it's so critical in that pivotal point in the event week. Our box 6 is probably everyone's favorite box when we do rapid improvement events, because this is where we actually start to do the work. They're getting to design those statements, or they're getting to design experiments around those hypothesis statements. So we have our if we do X, then we expect Y. So what are we going to do to prove or disprove that statement? Here we outline what the experiment is, what the anticipated effect is. We go out, run the experiment, we come back and document what that actual effect is, and then the follow-up action that we need to take. We also have a sheet that we hand out that we really force the teams to get really methodical and tactical in how they go about executing these experiments. We have them clearly define and lay out what the experiment is, how are they going to measure success, how are they going to know the experiment was successful. It has to be more than a gut feeling. And then we also have them anticipate anything that can go wrong. So they have a clearly defined plan when they go out. They talk to our frontline staff when they go out to run these events, and so they have a good guide of what's going on. Yeah.
So the RIE, this is taking place all week. Did your team fill out each box I mean, you don't do this all at once, right? I mean, you guys do this throughout the week, or?
Right, we do this throughout the week. So like I said in the beginning, we fill out these 3 boxes about 3 months before the event. We have several cycles of prep meetings with what we call the executive steering team, which are these people that's listed right up here. We have an executive sponsor, somebody usually like the CEO, CFO, CNO, somebody on that type of level who can really drive the improvements. Then we have a process owner, a team leader, and then we have us as the facilitator. But we spend a lot of time that 3-month prep on box 1 through 3, and then we bring the team in about box 4, like I said, to map out that current state and see what's going on. We walk through day by day. We usually can predict what kind of schedule they're going to stay on. We'll probably get through box 4 late Monday, early Tuesday morning, and then start moving into box 5 and 6. It really just depends on the pace of the team and then the problem that we're there to look at for the week. Does that answer your question, Colin? Okay. So box 7, this is our completion plan. So every item that shows up in the completion plan should directly relate back to an experiment that was conducted in box 6. We shouldn't have any extra things that don't tie in. We shouldn't just kind of throw something in there that doesn't have any direct relation to that box 6. The importance of box 7 is it just brings that accountability factor in to make sure that things do get completed and followed up on. So what we do, we outline what must be done, who is responsible, and when it will be completed, and then we monitor here based on the completion date if it's red or green. So that lets the executive steering team know, do they need to bring some muscle in, find out what's going on, why those completion items are not finished. Box 8, we're now in the checking part of the PDCA model. So what we're doing, we're taking the information that we put over here in box 2 and 3, and we're kind of monitoring 1 week, 2 week, 3 week, 30, 60, 90 days out from the event. We're going to watch for trends in the metrics. Are they red? Are they green? If they do turn red, that cues us as facilitators to kind of meet with the executive team and do some more root cause problem solving as to why those metrics are red. During the event week, maybe we needed to go back to box 4, maybe we didn't get all the way down to the root cause, maybe we didn't design the appropriate solution approach experiment. There's several different factors that can occur, but this is a good indicator of the progression from 2 to 3. And then box 9, a lot of us in the department, we consider this probably the most important box on the A3. So what this is the insights from the team for the week. This is their what helped, what hindered, those positive, negative things that happen, really their reflections on what they learned through the week. And it's really important for us moving forward, we can take what kind of they have given to us as their insights and use that in future events. Maybe we can learn lessons, not repeat the same mistakes. So that's how this box 9 fits into that whole PDCA model of thinking. So before I move on to flow cells, are there any questions about A3 thinking, the way it's set up, the methodology behind it? Anything? Okay, we'll move on to flow cells. We have recently started using the flow cell as a whole in the Med Center. We've ran a couple flow cell events, but you can see there's 5 main parts to a flow cell. We have 1 item flow, pull, standard work, 6S, and then everything's supported by visual management. So the flow cell forces teams to be really tactical in the way they go about identifying and removing waste from a process. And the definition of a flow cell, it's simply a natural grouping of processes that's been brought together to change an item from one state to another state. Everything in a flow cell is supported by visual management. It's very important that that visual management is there, that it exists, because it lets us know we can look from the outside looking into the flow cell, see if everything's right or wrong at a glance, and if something's wrong we can stop it right there, do some root cause problem solving, and get the flow cell working again. The deliverables that we expect from a flow cell, you kind of see them outlined here, but we expect that 1-by-1 flow on demand at the lowest cost possible with 0 defects. And we're going to go into all this later, but just want to give you a quick overview. So the first part we're going to talk about is that 1 item flow. So 1 item flow takes an item or a process, and you complete the steps one at a time instead of all at once. You don't allow the work to batch or build up. And then it's just a better use of resources. And when I talk about better use of resources, what do you guys think I mean when I talk about people, materials, and equipment as a better use of resources with one-by-one flow? If we're not allowing the work to batch or build up.
Less waste.
Less waste. Anything else?
Less inventory.
Less inventory, right? Anyone else? So if we use one-by-one flow, we're doing things one at a time. It's less steps, less motion waste. Same for materials. We have less movement of the materials. We're not waiting for equipment. Everything just flows at that rhythmic tone. If you think about how a metronome works, like this, that's how we have that paced flow. It just goes at a rhythmic tone. The example that I have up here from healthcare, it really goes back to what Brent talked about last month, are our guiding principles of VOS. We have continuous improvement and respect for people, patients, and society. So one-item flow demonstrates those because if you're taking items one at a time, it's easier to see those problems as they occur and conduct that root cause problem solving on the spot to improve that continuous flow. But for people, patients, and society, when we talk about one-piece flow, the example I have is we have a lab sample, and if we use one-item flow, we're going to take the lab sample, collect it, send it to the lab, have it analyzed, have the results interpreted, and then sent back to the physician or the nurse to share with the patient. That's very respectful to the patient because you're not expecting patient 1 to wait for their results. How it's usually done in the current state is we take sample from patient 1, patient 2, patient 3, patient 4, and if you have 30 patients, you're making patient 1 wait while patient 30 is having their lab sample drawn. So not only is it not respectful to the patient and conscientious of their time, but it can also cause some safety factors and as far as degradation of the sample, or if you have a blood sample, the blood can hemolyze, so some different things can happen. So one-by-one flow really sets that rhythmic tone for improvement. Any questions? The next thing we're going to talk about is pull. So we just talked about how flow exists without interruptions, and then we have 0 defects are attainable. So I'm going to put a question to you guys that we normally put to our rapid improvement event teams. How many feel that 0 defects in healthcare in general are attainable, that we can attain 0 defects in healthcare? You do? Okay. That's about what we usually get. We get 1 or 2 that think that. But then when we ask how many feel that 0 defects reaching the patient are attainable, that we can set up our processes to run so efficiently that we'll have 0 defects reaching the patient. Nobody? 1? 2? So we have no misinterpreted lab samples reaching the patient. We have just set up our processes so that no defects, they may be happening in the background, but we have no defects reaching the patient. We have no wrong site surgeries, no wrong labs done, no wrong tests done. So does anybody believe that now? Okay, that's about what we expect. Pull really talks about the customer triggering the action, and you're probably wondering why I have a picture of Subway, Moe's, Barbaritos, and McDonald's up here. If you were here last month for Brent's lecture, you've probably heard this, so just bear with me. But these 3 restaurants, Subway, Moe's, and Barbaritos, they actually showcase what a flow cell looks like and showcase a good example of pull. So when you walk into Subway, you walk up to the counter, you're pulling them for the action, because the first thing they ask you is, what kind of sandwich do you want? And then you tell them exactly how you want them to build your sandwich. You tell them the bread, the cheese, the meat, whatever it is you want on it. You go down the line, it has that one-by-one flow because they work at 1 customer at a time. You're entering the restaurant has pulled them for action. We're going to get into standard work, but they have standard work on how they set up a sandwich. Your sandwich is made exactly the same every time. And then they have 6S, which is the last element of a flow cell that we'll get into, but they have everything organized visually at a glance. You can see right or wrong if everything's going okay. And it's all supported by visual management. So when you think about how Subway works versus the way McDonald's works, you go through the drive-thru, you pay, you get your food, and then what is typically the first thing you do before you have to leave the drive-thru of McDonald's? Check your bag. Why do you have to check your bag before you leave? Because you have to make sure that your food is right. Have you ever had to check your bag at any of these other 3 restaurants to know that your food is right before you leave? So you can see how that pull from the customer triggers the action, and you can see all the elements of the flow cell in there. The last thing I have up here is increasing flow motivates improvement. So I'm going to ask you guys, what do you think that statement means when I say increasing flow motivates improvement? How would increasing the flow of a process motivate you to have that continuous improvement? Increase efficiency. What else? Come on, I know it's like 8:30. What else do you guys think? How can increasing flow motivate improvement?
I guess to me, if flow is increasing, I would say there'd be more of an emphasis on that, and maybe more people paying attention,
right?
Greater need to do it right, do better.
Yeah, you're on the right track. So what I have as an example for you is from the Toyota production line, which is where a lot of this lean improvements come from and where we've learned from, is on the lean production line, you have your workers sitting on the production line, and you'll have the supervisor of that line come, and they'll actually turn up the speed of the production line. They're not doing it to be mean, they're not doing it to be spiteful, but what they're doing is increasing that flow to push any existing problems to the surface. The workers on the line have been empowered to pull that and-on system. They can stop the line right there. They can do some root cause problem solving to figure out why those problems existed. Once they get to the root, put their solutions in place, then they can go back to the flow of the line, and then they can just crank it up again, and it's just a continuous cycle of improvement with pushing those problems to the surface. So I have an example from healthcare that we actually did over at Johnson City Med Center in the pharmacy with their IV room and their stock. What we looked at was their inventory dilemma, and I have some before and after pictures I'll go over with you. But they had a lot of the 8 wastes that Brent talked about last month, which is, was anybody here, and does anybody remember what those 8 wastes are? Colin?
MP would.
And they stand for transport, inventory, motion, people, waiting, overproduction, overprocessing, and defects. So all those are pretty much represented here. We have high inventory, we're counting, we're looking, we're moving parts around, and this is what the pharmacy experienced with their inventory in their IV room. So in their previous current state, they had a push system. So instead of making all we can just in case, they just stocked all that they could just in case because they didn't want to run out of anything. It caused them to have high inventories, lots of waste. They have lots of management by firefighting, which we'll get into that in just a minute, and lots of poor communication. They couldn't visually at a glance see what they were missing, what was expired, what they needed. When we implemented what's called a 2-bin Kanban system in the pharmacy, it moved them into a pull system for their inventory replenishment. So they make what's needed when it's needed, or they stock what's needed when it's needed. It caused them to decrease their inventory. They had that waste reduction, more management by site, and better communication. So when I talk about a 2-bin Kanban inventory system, what it simply is you have 2 bins. They sit behind each other, or in this case, they're going to sit on top of each other. You have the same amount of inventory in both bins, probably about 1 to 2 days. Use all the inventory in bin 1. When it's empty, you take it out, put it in a designated drop zone to be replenished. Pull bin 2 forward, use all inventory in bin 2, put bin 1 back behind bin 2, and then you have that constant rotation of inventory. So this was the before pictures. You can see it's really messy. At a glance, you can't really see what they have, what they don't, what's expired, what they need. They had weeks to months of inventory in just overstock in their IV room on their shelf. So like I said, we did the 2-day inventory in their 2-bin Kanban system. This was done during a rapid improvement event last year in the pharmacy. And after the week was over, at the conclusion of the week, they were able to remove about 907 items of inventory off of their shelf that was just purely overstock. So you can see how that would lead to a lot of other problems, especially if you have supplies that are going to be expiring. It's just throwing money down the drain. So that 907 items that they removed equated to about $15,000 in overstock that was sitting on their shelves. They were able to take this off and send it back to their main stock of inventory. And then I have some pictures of after, so you can see the difference from the before to after. They've implemented the 2-bin Kanban. Like I said, theirs are on top of each other. The bins are really close together by design. We had a lot of people complaining about that at first, but once we explained the thinking behind it, so you can't reach your hand back in there and use inventory on the second bin before you get all the inventory out of the first bin. It's been very successful. The staff really likes it. It's made it a lot easier on them because the technicians are in charge of making sure that this shelf is refilled. So just simply by saying I have to have 10 in this bin, 10 in this bin, when I know this bin is out, I can put it in the drop zone, and then I know automatically that I need to stock 10 back in there and rotate it back into the inventory. These are some other examples of pull systems. You may not realize it, but even things like your gas tank, that is triggering you for some kind of action. So a couple other silly examples. We have the dog's water dish, the can rotator, and then even vending machines themselves are those pull systems that you see in everyday life. So any questions about pull systems before we move on to standard work?
Give me other examples of that. I'm having a hard time. The inventory is a great example. Is there any other examples that you can throw out there that you guys have done? I see, as an administrator, I struggle with this all the time. Mm-hmm. How do I? Because I always wanted to put something pulse. I didn't know it was called a pulse system. Mm-hmm. Pulse system in place, and I always got kickback from clinicians if we don't have enough staff to do that, or we don't have enough this. What other examples do you have out there?
Well, and we see that at the hospital too, as far as resistance from staff, or we don't have enough staff. The thing about lean that can make it very difficult, while all this seems very simple, and when you hear it, you're like, oh yeah, that does make sense. The thing about lean is it is a cultural transformation change that has to occur. It's very, very hard, especially if you have employees that have worked at an organization for 30 plus years. They're used to doing the same thing the same way every time. It's very hard to get that cultural transformation implemented. But once they do get it implemented and they see the value of it, it's kind of something just clicks in their head, and it makes it a little simpler. Some other examples of pull systems that I can think, and I may have Whitney, who works with me at Voss, help, but we had an admission flow cell that we created, and I have a video. If I have enough time, I'll show it to you. But we have an admission flow cell that we created, and a pull system, even in that admission flow cell, is just the patient being placed in the room. So that's just one part of the flow cell that pulls for the trigger for action. Does that answer your question? Okay. So the third part we're going to talk about is standard work. I'm going to pass this out while I'm talking, and we'll go over it in just a second. But standard work is that foundation of continuous improvement, and it's the best known way right now. So when I say best known way right now, why is it just not the best known way? Why does it have to be the best known way right now? Always room for improvement. So I may know the best known way right now, but 5 minutes from now it may be completely different because circumstances have changed. We've learned something that we didn't know 5 minutes ago. So it's just that constant rotation and that constant continuous improvement. And I have a visual up here. It really does give a good insight into an event week and how important standardization is when we're trying to design these new processes. You can think of the rock that this little guy is pushing. This is all the work that was done during an event week. All the experimentation, all the insights that we learned, everything that we design is in this rock right here. The guy you can think of as that wedge of standard work. So the standard work is in place, and it's constantly pushing all of these processes up the hill of improvement. So we have that continuous improvement. We're continuously learning. What standard work also does is it promotes root cause problem solving versus firefighting. So do you guys know the difference between root cause problem solving and just simply firefighting problems? No, I see some heads shaking no. Can anybody take a guess at it? What does root cause problem solving versus firefighting mean? Come on now.
The problem at the source, and you don't have to keep putting a Band-Aid on it.
Right.
Or dealing with the emergencies every time. So if you take care of the important things, you will reduce emergencies.
And that's exactly right. The example, it's going to sound really silly, but the example we give out during rapid improvement events is, if you go to an arcade and you think about the game Whack-A-Mole, what happens? The little moles pop up and you whack them down. That's firefighting. You're not doing anything to solve the problem. You're just firefighting and putting them out as they come up. Root cause problem solving is really taking a step back, thinking about, okay, why does this keep occurring? And then coming to the realization that if I unplug the machine, they're not going to come up anymore. I've went to the root, I've solved the root cause, I'm done with firefighting, and now I can move on to other problems. So the little example that's going around, this is an example from a charge capture RIE that we did at the Med Center a couple months ago. What was happening in the previous current state is a patient would come in, they would be assigned a card. All of our supplies were stickered for the ones that can be charged for. Nursing would take the sticker off the card, off the supply, put it on the card, put the card in the chart, and hope the card made it down to central supply so that we could charge for those items. You can guess it didn't go over too well, and we were losing out on a lot of things that we could charge for. So what the team did through experimentation, through the course of the RIE week, they discovered that we actually have the capability to scan those charges in real time into the nurse's MAC cart, which is their medication administration carts. They also use it for charting, and every nurse has one. So they discovered that they can just simply scan a barcode. I think they actually made this one off somebody's smartphone. That's for blood charges. And scan it in real time. So the team come up with this standard work to follow. It's all about that size of the card. It's on every MAC cart at the Med Center, so every nurse knows the process and does it the same way every time. It has standard work on how to capture the charges. It has standard work on if I pull an item and I charge it, but I don't need it, now I know how to credit it back. And on the back, it actually has what to do in the case of a downtime procedure, so we're not able to scan in. So everybody's doing the same thing every time, and we've actually seen our charges drastically increase because we're able to capture so much more. The other example of standard work relates back to the two-bin Kanban system that I talked about. This is posted right on the wall beside the Kanban system. It just gives that visual representation of the bin's empty, I pull it and put it in the drop zone, I rotate the next one forward, I clean the empty bin out, I restock it, and then I replace it. So not only does it have that visualization, but also has the step-by-step instructions so everybody is clear on what to do. Standard work, pretty simple. So the last element that I'm going to talk about is 6S. It doesn't mean anything special. It's just 6 words that start with an S. It's sort, straighten, scrub, safety, standardize, and sustain. So in sorting, it's more than just organizing. We're really looking at our inventory, looking at what we use on a daily, monthly, quarterly basis, or what are those things that we use in a blue moon. We remove clutter and items. We separate out, like I said, daily, monthly. The ER actually did an event a couple of months ago where they 6S'd one of their clean holds, and they pulled out some supplies that they use maybe once in a blue moon, but when they needed them readily available and very quickly. So what they did is they created a once in a blue moon cart. It sits in their clean hold, so it's there if they need it once in a blue moon, very quickly accessible. So after we sort, we're going to straighten, and that's just making sure we've straightened everything out, all the likes together. So if I was 6S'ing a desk, I would make sure all the pens are together, all the pencils are together, the staplers, whatever. And then we remember back to the adage of a place for everything and everything in its place. So we make sure everything has an outline place and everything is together and organized. Then we move into scrubbing. So we're bringing that area to a new standard, and we do this not just to make sure that it's clean, but to make sure that we make safety hazards, things like leaks, stand out against clean areas. So if you go into a hospital, you'll often see a white wall against a white floor. That's done on purpose so we can make things like leaks, blood spills, different safety hazards stand out so we can take immediate action on them. Then we move into safety. Safety is just reviewing the 3 previous stages and making sure that we haven't overlooked any safety hazards that are out there, and if we have, making sure that they're addressed. Then we move on to standardizing. So standardizing is different than straightening. Standardizing is, okay, I have 5 desks that I need to 6S. I've straightened, I've sorted, I've straightened, I've scrubbed, I've made sure any safety concerns are addressed. But now I want to make sure everything's standard from desk to desk no matter where I go. So if I sit at this desk, I want all my pens to be on the left-hand side. If I move to that desk, I want to make sure all my pens are on the left-hand side so I know exactly where to go and exactly where to look no matter what area I go to. And then back to your point, Colin, this is what I was talking about is the hardest part of lean is the sustainment, because you do have to make it that transformational culture change. It's not easy, it's not always pretty, it is very tough, and we see it every day on a daily basis. We have people that do come over to the lean side very quickly, and then we do have those that it takes a little bit longer, but it's just because you do make that process part of a culture change. These are some more examples from the Med Center. I don't unfortunately have any before pictures, but these are after pictures. All the clean holds were 6S through an event with nursing and our department. They went through with each nurse manager and frontline nursing, looked at their supplies, looked at their uses for the last year, looked at those things that you used on a regular basis, and then those once in a blue moon things, completely cleaned out the clean holds, sent any supplies that weren't used on a regular basis back down to our central supply department, and then started to work on color coordinating everything. So no matter what clean hold you go to in the Med Center, all of your IV and needles are going to be in this pink zone. You're going to have all your ADLs, your activities for daily living, you're going to have all that in the green zone. Wound care is in the red zone. All your specimen collection things are going to be in the orange zone. So visual, at a glance, same from unit to unit. You know exactly where to go to get what supply you need. And here's some other examples from over at the hospital. Here's a desk that was 6 desks. You can see all the supplies have been laid out, and at a quick visual glance you can see right here something's missing, probably a tape dispenser or something, but it has some wording that indicates to me this is what I need to go look for. This is exactly what's missing from my desk. This is out of the ED. This is color coding for charts. So what has been done is we have a red zone, green zone, blue zone. So maybe the reds mean there's some lab issue that needs to be addressed, blue, some respiratory issue that needs to be addressed. And this is actually a great example of 6S. Here's a before of a surgical tray. Can't really tell at a glance if you have everything. If you don't really know it's there. It's all looks like it's just kind of been thrown on there. But after a 6S was done and 6S all the trays and surgery, now we have an outline for everything. Everything has its place. We have wording to let us know how many of what's supposed to be there, what we need to go look for. Very good visualization of 6S. Any questions? Okay. So just to end on a good note, before I show you the video of the flow cell that we did at the Med Center, we're going to do a little exercise, and everybody on the front row, you just volunteered for this exercise. So I'm going to hand you a sheet of paper. Don't turn it upside, or don't turn it around yet. Oh, I have one extra. You're the lucky person. What I want you to do, there's going to be numbers 1 through 50 on this sheet. You're going to go through, and all I want you to do, does anybody need a pen? Or does everybody have a pen? Here you go, Whitney. Give that to that guy. So all I want you to do, 1 through 50, I want you to take your pen, connect 1 to 2, 2 to 3, so on, so on, so on. I'm going to give you 30 seconds. Should be able to get it, right? It's just 1 through 50. Okay. So ready? 30 seconds, 1 through 50, go. So for everybody else, this is what they're looking at. this is what we call the current state. Very junky. I don't even know where number 1 is. Oh, I see it now. Nothing's been cleared out. We've not sorted anything. This is what we typically see and what we use as a visualization to our teams for current state. Very messy. Not able to really start any kind of improvement projects because it's just so messy. Okay, you got 10 seconds. 8, 7, 6, 5, 4, 3, 2, 1. Okay, everybody stop. So who got 1 through 50? Who was able to get 1 through 50? Who got 1 through 10? 1 through 5? 1 to 2. Who connected 1 to 2? Okay. So what we're going to do, the next thing we're going to do, we're going to go through sorting. So again, I have another sheet of paper for you. Don't turn it over yet.
Can we pass this?
Yeah.
So that they can do it?
Don't turn it over yet. I'm going to give you 30 more seconds.
Oh, don't turn it over.
1 through 50, you're going to connect 1 through 50. 30 seconds. Ready, go. So for everyone else, this is what they're looking at. So we've sorted all the junk out. We've sorted out all the things that we don't use. A little better visually to see, but you can still see the importance of walking through those 6 S's. I can see 1 and 2 more clearly now. Still don't see 3. What time?
22 seconds from 3.
5, 4, 3, 2, 1. Okay. Who got 1 to 50 that time? Nobody? 1 to 50? Did anybody get 1 to 10? Well, we're fixing to find 10. So the next step that we're going to go through is going to be that straightening phase. So we've looked at the current state, we've went ahead, we've mapped it out, we've sorted, we've gotten all the junk out. Now we're going to go through straightening. So 30 more seconds, 1 through 50 again. Ready, go. So we've straightened. This is what they're looking at. This is straightening. So we don't have everything in order yet. We just kind of straightened, but very visually easy to see. We can see 1, 2, 3. Probably connect a little bit more numbers this time. We've already been 20 seconds. Got 5 seconds left. Who's going to get it? I know we're going to get 50 this time. Okay, 30 seconds. Did you guys do better that time than you did the previous 2 stages? Yeah? So the last exercise that we use, and we use these on our events quite often, it's a silly little exercise. It gives you a good mental break, but it does drive home the point of the importance of success and how important it is to walk through each stage and not just stop at 1 and move on. So this is going to be the last part of success. 30 seconds, again 1 through 50. Ready, go. So everybody else is what they're looking at. I feel everybody's going to get 1 through 50 this time. I know it. And I'm going to guess that we're going to have time left over. So when you're done, turn your paper over. Oh my gosh, we have 10 seconds remaining, and we got all the way through the 6 S's. So, like I said, 6S, silly exercise, but really drives home the point and the importance of completing that good 6S. And the last thing I have before we get back to the objectives, I don't know if the volume will work, but I can talk through of what's going on. Oh, it sounds like it's going to. Very low. But this is an admission flow cell that we recently did at the Med Center. The team walked through the A3 thinking. They were educated on all the importance of the flow cells, each section that we just went over. And what we were seeing is there was a real fragmented process on just admitting a patient into the hospital. Nobody's on the same page. Nobody knows what's going on. The patient's very frustrated because they get asked the same question 50 times by 50 different people. So what the team did is they actually brought that care team model in. They put the patient at the center of the care. They brought the care team model in, so we have the physician, the nurse was over here, and this lady is the med rec tech. So when there's admission into the hospital, they all go into the room together.
Megan, and she's going to ask you some questions about your home medications, and the doctor will be in with us in just a minute. And we'll go over a series of questions to get you admitted in the computer and to get you started to get your care.
The pull is the patient in the bed that's pulled them for the action. The one-by-one flow, they're interviewing one patient at a time, not getting mixed up, not batching, which is what we normally see. Go in to interview 5 patients at a time, sit down, do all of our charts together. There's standard work. Each role knows what they're doing, knows what to ask, knows what their importance is in the flow cell. And then the 6S, I don't know if you can see it. It's really more on their, these are the MAC carts, and on their screens, 6S, everything's visually organized. I won't make you sit through the whole thing, but this just goes over the flow cell that we created here. And then we've also done another flow cell event down in the ED as far as door to discharge.
Technician here with the hospital. Just had some questions for you about medications that you take at home. So I look in the system and I'm not showing anything. Do you take prescription medications?
The only I have a Fareva inhaler that I just use as I need to.
So you can see the pharmacy tech, who is somebody that has been trained in home medication collection. It's very detailed, very in-depth. She's specifically trained for that. She's in the room asking the questions. The doctor's in there. The doctor knows what they're on. The nurse is in there. They know what they're on. The nurse is charting. The doctor's listening, and the tech is charting as well.
Actually, that whole IDT team, they're getting in there on mission each time?
They actually started running it yesterday.
Is that a struggle to get all those people together at one time to do this?
They've come with some challenges just because of staffing, which is the excuse that we hear a lot. And we know that everybody in healthcare is short-staffed right now. But once we took this, or once the facilitator, a coworker of mine, took this out along with the team and kind of explained it and explained that this is in the best interest of the patient, it's hard to argue not doing this when it's the best thing for the patient.
The best interest of the IDT team, because of the interdisciplinary team, because they're all hearing the same thing.
Right. And you're not playing, if you think back when you were little, you played the telephone game. That's usually what is happening in hospitals when you don't have good processes and good admission processes to get the patient in. We've seen patients come into the hospital that have their discharge orders entered before their admission orders are entered. So we see that stuff happening, and we're hoping by implementing this flow cell that it'll help combat some of these problems. Now, the thing to understand is it's not going to be a quick fix. Lean is not a quick fix. It's very hard, it takes a lot of dedication, a lot of time and effort, but the end result is the most rewarding thing because you do make the experience better for the patient.
How quickly are they all getting in there?
I haven't been able to talk to him because they just started it yesterday. I haven't got any data back yet, but I think they completed this patient admission with all the information they needed in 12 minutes, which is very fast if you think about how long it usually takes to get a patient admitted.
How will it affect the difference between like a day shift and a night shift? Because obviously it is a little more of a skeleton crew at night.
Right. Well, what they did, we really used the 80-20 rule. So 80% of our admissions are happening during the daytime, but we do have a contingency plan for those 20% that do happen in the evening. Pharmacy, which is who this person works under, they've actually reworked the technician schedules. So they're here till about midnight or 1 a.m., I think, so they can be brought into that flow cell process. But if they're not here and they do have to complete this flow cell, each party knows what their duties are because it was laid out in the standard work. So if the technician is not here, they either know they need to come in first thing in the morning and go address this with the patient, or it becomes the responsibility of the nurse, and that's all been laid out in the standard work. Yes?
You're thinking about the planning process. How does it change when a metric is a longer-term outcome? So you're looking at 3-month outcome, you can go to A1C, or 2-year job placement rates, or something like that. How does that impact your planning process?
So when we look at the planning process, the there's different events that we can conduct. So we have rapid improvement events that are done in the week, and those are events that close typically within 90 days. But those events stem from what we call a value stream analysis, and those are things that last up to 18 months. So we have metrics on the value stream analysis that we're constantly looking, constantly watching, and things like this RIE are created to drive those metrics of the VSA, so we can see 18 months out. Even if this event has closed, if we start to see that metric slip on the VSA level, which is the higher level over the RIEs, then we can go back and look at the rapid improvement event again and say, where was the breakdown, where was the degradation, and what kind of solutions do we need to look at? Does that answer your question?
Yeah.
Okay.
Some of the process requires quick feedback from people that are recalcitrant to change. Mm-hmm. And yet some of the metrics have to be year, 2 years.
Well, and for those that require quick feedback, that's the importance of us conducting the rapid improvement event week and doing those rapid experiments. So we typically push our teams as the facilitators. It's our job to make sure they go through several cycles of improvement events through the week. We typically like to see between 8 and 10 cycles of improvements. And what we have them do on a smaller scale to see if that improvement is going to work is we have them monitor the metric for the week to see if it's going to work and see if that continuous improvement is going to be put in place. Anything?
You could potentially have a number of rapid improvement events that feed into or that are supportive of your long-term metrics.
Right. So we just had I'll give you an example. We just had a value stream analysis for our inpatient value stream. They came out of their value stream. Value streams you can think of more as a planning type session. So they came out of the value streams. They identified 8 rapid improvement events that needed to happen, along with about 12 to 15 projects that they needed to take care of. So all those things are going to work to push on the value stream level, and then those in turn affect on the corporate level. Is there any other questions? Then we'll move on to, just want to recap the objectives. So can you guys relate A3 thinking to the PDCA model of improvement? Was that outlined clearly on how we walked through box 1 through 5? That's where we spent a lot of time planning. 6 and 7 is that doing, 8 is the checking, and then 9 is the acting. This is the test. Can you name the 5 elements of a flow cell that I went over today? Somebody take a stab at it.
Visual management.
Visual management. That's one. Come on, we just did an exercise on it. Success. Pull. One by one. Standard work. Good job. I did teach you something good. So I have that all up, just a quick recap of what each different element means. So like we said, 1 by 1 flow, completing those tasks one at a time and not allowing the work to batch or build up. We have that customer pool is linked to real-time demand, the best known way right now for standard work, the 6 S's, and then the visual management is the foundation of that flow cell. And then the last thing, just giving you those examples in everyday life. So we talked about Subway, we talked about Whack-A-Mole, but then showing you examples from healthcare as well. And that's all I have. If you guys have any questions, I'll be happy to try and address them. Okay.
Questions to Jenny? No?
Oh, no, actually, Demetrius got a question.
Okay.
Early in your introduction, I saw you had your name and your credentials, I guess. I saw CMRP. What does that stand for?
It's a Certified Materials and Resource Professional. So before I came to Voss, I worked in corporate purchasing at Mountain States. And it's just a certification for those that work in purchasing or supply chain. It's a Certified Materials and Resource Professional. It's just like any other credential you can get. Nurses, if you work in the emergency department, you can become a certified emergency room nurse. That test took me about 3 months of studying and a very excruciating 2-hour test to get that credential. So, but there's all kinds of credentials out there, so I really strongly encourage you when you graduate and go wherever you're going to go to work to look and see what kind of credentials are out there to certify you as a professional in your field.
I have a question.
Yeah.
I did my internship at Johnson City Medical Center, so I was on a couple of RIUs. And something that I found that was happening was different improvement events were clashing with one another. You mentioned that the admission process was, the discharge of the patient was actually taking place before the admission paperwork actually went through. And one of the events I was on was the discharge process.
Oh, okay.
So how do you handle those clashes?
So that's where we see that. So typically in a month, we'll probably have 8 rapid improvement events going. We are all on different cadences. We have about 10 value streams open right now. So when we still are set up to where we have inpatient, ED, OR, there's inevitably going to be crashes between the value streams. And it's just through continuous improvement and our own learning and understanding how we kind of morph those silos. So we're set up like this, how we morph those silos into an inpatient stream and an outpatient stream. So we've done a couple things, just better communication. We've encouraged better communication between our senior executives just on what's going on in the value stream so that we can bring that more collaboration together. Like with the admission flow cell process, we brought pharmacy in, we brought nursing in, we brought physicians in, and all the departments that had a stake in that. Anything else?
Other questions? Okay.
All right, thank you all.